Hello, this is Shadi Rais from MidStar Washington Hospital Center. Today, CVI 2017, day one. With me is Abdulah Rifai. He's from University of Miami GFA Medical Center. He's a second-year fellow, general fellow, but he's interested in intervention. Welcome, Abdulah.
Thank you, Shadi.
He presents to us a very interesting case that he already published, but it's very interesting to share with the audience who didn't have a chance to attend the meeting. Go ahead.
Thanks, Shadi, for having me. So we'll talk today about the case we did in our hospital, a patient who presented with a severe aortic stenosis who carry a history of dextrocardia, and they had a single coronary artery. So the learning object for the case basically is to share our experience in dealing with such a difficult case, something I think is pretty rare. If when we did the literature search, there's only one case published without any actually single coronary artery. So this is the first case with the TAVR for dextrocardia and single coronary artery. So our patient is an 89-year-old gentleman who carries a history of hypertension, diabetes, and hyperlipidemia. And also he knows that he has a dextrocardia. So the patient presented initially to the hospital with progressive chest pressure and dyspnea and found to be in CHF, New York Heart Classification Class 3. The patient also sustained a syncope prior to present to the hospital also. On physical examination, the patient had a systolic ejection murmur as a 4 out of 6, which was crescendo, decrescendo, found to have irregular rhythm with the rales, bilateral lungs, and lower extremity edema. But he was stable at that time. The EKG that was done in the ER, since we know that the patient has a dextrocardia history, it was a right-sided EKG basically, and as we say, the patient is in AFib at that time. Chest X-ray shows the pulmonary congestion and the dextrocardia as well. At that time, since the patient presented with a congestive heart failure, an echo was performed, and it shows basically, if you look at the ventricle, has a mildly depressed, about like 45 to 50 ejection fraction, with a severely classified aortic valve with reduced movement to the leaflet, basically reduced excursion to the leaflet. When we did the Doppler to the aortic valve, it basically, he had a mean gradient of about 50 or 48 millimercury, which consisted with severe aortic stenosis with Vmax, with velocity max of about 4 meters per second. At that time, since the patient carries a dextrocardia history and presents with severe aortic stenosis, the decision was made to go ahead and plan him for transaortic valve replacement. So the patient is automatically, as we discussed in our meeting, is a high-risk patient since because of his age and his other comorbidities. So a CAT scan that was done at that time showed the minimum coronary height was 16 millimeter, and the annulus area was 420 millimeter, which basically Sapien S3 valve, size of 23, would be probably the size that we would use in this case. So the patient then was transferred to the cath lab, and when we cath them, we noticed that the patient has one single coronary artery that trifurcate into left anterior descending artery and the circumflex and right coronary artery. In the second shot, for the aortogram, we confirms basically that there is a trileaflet aortic valve, basically. Another image for the coronaries, which was basically a single coronary. Then after the meeting, with the multidisciplinary meeting, and very careful actually planning for this case, since not really many cases documented in the literature about TAVR for dextrocardia with a single coronary artery. So we had a very careful and multiple imaging done for this patient to confirm the coronary height and what's the best approach. So we proceeded with the transfemoral approach for this patient, and as we see here, At that time, we used to do standard BAV before our TAVR. Now, it become less something we less use, as we know the literature suggests that those patients, they might sustain more risk of stroke, basically, when if we do standard BAV. Under rapid basing, we deployed the valve, which was a Sapien S3 23 millimeter. It was successfully deployed. And then also it was part of our standard practice. We did at that time is doing TEE. We don't do it that much anymore, but under the TEE and the fluoroscopy, we confirmed the excellent position for the valve with almost none perivalvular leak, actually. The patient did very, very well. We saw him in 1 month and 6 month follow-up. The reason basically we're sharing this case today, it's the first reported case of TAVR in patient with dextrocardia and single coronary artery documented in the literature. So we want to stress how important is the planning with the multidisciplinary team and take care of images for those cases and plan it very carefully. And it is feasible and safe for those cases. And thank you so much.